Back in the BGICC conference, as usual, in the radiology session. I would like to welcome you all, and I would like to thank the organizing committee for such a wonderful conference that we really wait for it every year. And of course, the radiology sessions in particular are quite important and very well organized, thanks to the organizing Professor Rasha Kamal, who did really a wonderful job as usual. And I would like to welcome all our guest speakers from outside Egypt. And I'm sure you will all be excited to listen to their presentations. And just because of the shortage of time and because we are already late, I would like to start the conference, but please, before we start, I would like all of you to switch your mobile or cell phone to the silent mode. And I would urge our speakers to stick to the time allotted and just to make it, everything goes peacefully and good. So, I will now give the mic to my colleague, Professor Hala Busenna, to introduce our first speaker.
I just have a short welcome note.
Go on.
Bismillah ar-Rahman ar-Rahim. I'm deeply honored to welcome you all, dear colleagues, in the 15th BGICC conference. I'm very grateful to each and every one of you. Your attendance and active participation is the key of success of this conference. The BGICC has always been a great chance for all those working in the field of breast and female pelvis oncologic care to meet and share experience. I would also like to thank my colleagues in the Egyptian Society of Breast Imaging because without their help and support, I wouldn't have been able to prepare this conference. And in specific, I want to thank my dear colleague and friend, Merit El-Maddawi. She's the corner of this conference. I'd like to welcome all the international speakers, Professor Jessica Leong, Professor Shil Palat, Professor Tanya Shaula, Professor Janaki Dharmarjan. And we have with us also online speakers, Professor Laszlo Tabar and Professor Michael Limver. The program is divided into 2 days. In the first day, we have 3 sessions. The first session is breast imaging, new trends in breast imaging. The second session is a female pelvic imaging, updates in female pelvic imaging. And the third session is challenges and pitfalls in breast imaging. On Friday, we have 2 sessions, one before the Goma prayer, uncommon breast lesions, radiology pathology correlation, and one after the Goma prayer, the breast imaging in young women, case-based review. At the end of the second session, we will announce the winners of the Radiology Rising Star competition. Actually, we intended to make 3 case presentations, but the cases were very extraordinarily nice, so we had to choose 6, and out of these 6, we will choose 3 winners. I want you all to participate in the artificial intelligence aided mammogram versus contrast enhanced mammography. This workshop is supervised by Professor Sahar Mansour. You can, if you want to register in the AI, you have to contact Mr. Abdulrahman if you want to take his phone number. I put it here on the slide. We also have 2 breast intervention workshops. One is today starting 2 o'clock, and the other is tomorrow starting 5 o'clock. هو ممكن رنا can you please tell them outside يعني we start the same ما ينفعش نشتغل في الدوشة دي. Let me wish you all an enriched, fruitful, and knowledgeable learning experience, and thank you. Yes.
Bismillah ar-Rahman ar-Rahim. It's my pleasure and honor to introduce our dear Professor Rasha Kamal for the first presentation in this session. Professor Rasha Kamal is the professor of radiology at Cairo University. She's the chief consultant at Bahia Breast Cancer Hospital and the president of the Egyptian Society of Breast Imaging. And her first
لا،
presentation
مش عايزة
today will be
presentation.
about contrast enhanced
لا،
mammography, workflow and economics in breast cancer institute.
انا مش بعمل اي نوتيفيكيشن، انا مش عايزه ده، انا عايزه البرزنتيشن العادي. العادي لا ما تبقاش اللي هو مقسوم، انا مش عايزه المقسوم ده. فول سكرين. ايوه بس. بسم الله الرحمن الرحيم. My first lecture is Contrast Enhanced Mammography, Workflow and Economics in Breast Cancer Institutes. Over the past few years, we have witnessed dynamic changes in the investigation and management of breast cancer. And it was found that the only way to curtail breast cancer is by coupling early detection together with a proper diagnosis in order to be able to give the patients the most adequate and appropriate treatment options. And of course, we as radiologists play a fundamental role in this part. And this is the reason why every day we witness continuous development of new technologies in the field of breast imaging. These technologies bring about changes in the workflow, or in other words, they affect the productivity of breast imaging units, but in the same time, they raise concerns about some economic constraints, or in other words, this technology has an impact on the time, on the cost, and on the patient management. And from this perspective, I'm going to discuss with you today my experience working with contrast-enhanced mammography in two of the busiest breast cancer institutes in Egypt, and this is Bahia Breast Cancer Hospital and Asr Al Aini Cairo University Hospitals. I will start by discussing the impact of contrast-enhanced mammography, productivity against time. In Bahia Breast Cancer Hospital, we receive around 400 cases per day. We perform 50 to 60 contrast mammography examinations per week as compared to 15 to 20 MRI examinations. And in spite of this large number, we are still mainly concerned with providing flawless screening and diagnostic services to our patients because we strongly believe that patient convenience is the only way to reach a high compliance rate. And this could not be achieved unless we succeed to decrease the number of steps that the patient takes from the time that she is diagnosed to the time that she is managed. And that's why we have adjusted our schedule in such a way to allow for add-on exams to mammography and ultrasound in order to reach an accurate diagnosis in the shortest period of time. And when we think about add-on exams, these might be contrast-enhanced MRI, contrast mammography, and sometimes even we perform the biopsy on the same day when the patient comes. And if we are thinking about an add-on exam, whether MRI or contrast mammography, we should make a comparison between both to know which is more suitable as an add-on exam. Contrast mammography is actually less time consuming, better tolerated with a relatively lower cost. It's easier to interpret, and we can still assess the microcalcifications on the low energy images, which are exactly like the mammographic images. So if we're thinking about an add-on exam, definitely we would choose contrast mammography and not MRI. But we have to be fair enough to admit that still MRI is the top-notch modality in diagnosing breast lesions because of its multi-sequential and multi-planar imaging capabilities, which allow better lesion detection and characterization. We'll move another step and discuss contrast-enhanced mammography productivity against cost. Healthcare providers are mainly concerned with developing appropriate strategies to resolve the conflict between the demands for providing high-quality services on one hand and economic efficiency. Or in other words, they have to balance between the anticipated clinical benefit that the patient gets against the potential economic impact. And in today's cost-conscious environment, even new imaging technologies that have the potential to improve breast cancer detection and diagnosis may become questionable if they necessitate additional investment in buying new equipment, training radiologists, technologists, and referring physicians, finding a place to place this new technology and the added used material with this technology. Concerning the equipment, before applying any breast imaging modality, we have to make sure that it will really add to all modalities in diagnosis and management. And the preliminary studies showed comparable clinical performance for contrast mammography and MRI, and higher performance when compared to digital mammography. Yet when buying new machines, we still make our comparison based on equipment differences. Contrast mammography is definitely a lower cost procedure when compared to MRI because the system cost is lower and the procedure time is shorter. But on the other hand, it is a higher cost procedure when compared to digital mammography because the system cost is higher and the procedure time is longer. And now we move to training. The speed of adoption for new technologies in the field of breast imaging is likely to vary according to the ease of training and acceptance of radiologists, technicians, and above all, the referring physicians. Referring physicians must be persuaded of the potential value and improved outcomes of this technology. And from a practical experience, we can clearly declare that both oncologists and surgeons find contrast mammography easier to interpret than MRI. And after an initial short resistance period to any new technology, they are now more and more dependent on contrast mammography in the preoperative diagnosis, staging, and in the follow-up of the patients. And a sentence that I usually hear from my colleagues, oncologists and surgeons, we really wonder how did we manage our patients before we had contrast mammography. And moving to the place, there is no need to set up a specific space within the radiology departments to fix a contrast mammography machine, as the same mammography system can be used for high volume screening and diagnostic workup. Other possible advantages of contrast mammography include easier access to the equipment and shorter waiting lists, particularly at sites and times with limited MRI availability. And lastly, the material. The contrast material used is the well-known and relatively cheap contrast medium used in CT and IVP, but definitely the use of contrast media comes with an added cost, increased time of examination, and increased risk of side effects. And now we come to the most important point of debate, productivity against patient management. As radiologists, we are asked to provide the best imaging options for our patients. And to achieve proper patient management, whenever we encounter a case with suspected breast cancer, we should pass through several steps. We first have to look for this cancer or detect and characterize this cancer. And if cancer is diagnosed, we have to stage this cancer or know how far has cancer spread. And lastly, when the patient is treated, we have to follow up the patient or determine if the treatment has worked. And we'll start by the detection and diagnosis. Up till now, the only validated screening modality is the mammography, which has always been used as a detection modality, and it might be coupled with an ultrasound examination to yield the best outcome. And when MRI was first introduced, it was thought that it will play its main role as a diagnostic modality, but recently it was also added as a detection tool for patients with a high risk of developing breast cancer. And the question here, where does contrast mammography stand in this equation? Actually, contrast mammography, having the merits of both mammography and MRI, I think in the future it will, up till now it's playing its role as a diagnostic modality, but it has the potential to be used as a screening or detection modality in high-risk individuals. I always say that in screening, we usually follow the traffic lights, where the female population is classified into an average risk population with no specific risk of developing breast cancer, a moderate risk individual, which have an increased risk ranging from 15 to 20%, and the high risk individuals who have a risk which is higher than 20%. For the average risk and most of the moderate risk individuals, it's only mammography for screening starting the age of 40, and it might be supplemented or complemented with an ultrasound examination. And for high risk and selected moderate risk individuals, in addition to mammography and ultrasound, we add MRI, and this starts at an earlier age than the normal or the average risk individuals. Contrast mammography, yeah, it has the potential to be a primary screening modality. Instead of doing mammography and MRI, we can combine both modalities together. But up till now, the validated results state that contrast mammography can be used on recall to characterize detected lesions on screening. And recently, there was a manuscript that was published in the Radiology, and they found an added role of contrast mammography in screening women with an increased risk of breast cancer. This is a high-risk patient with a strong family history, and this is the usual appearance of high-risk individuals. They have this heterogeneous dense breast parenchyma where we can point multiple areas of concern. But where the true area of concern is only seen on contrast mammography with having this multifocal lesion in the left lower quadrant breast. This is another moderate risk individual. She was recalled because of this focal asymmetry in the left breast. On recall, we performed a contrast mammogram, and it was not a single lesion. It was a multicentric carcinoma of the left breast. Now we move to the use of contrast mammography in diagnosis or in lesion characterization. We've performed many studies in Asr Al Aini, Cairo University Hospital, National Cancer Institute, and Bahia Breast Cancer Hospital, and some of them are already published a few years ago. And the clinically proven results from published studies have shown that contrast-enhanced mammography increases mammography sensitivity and specificity. That means that more patients will be sent home avoiding further workup, or in other words, it will help reduce patient anxiety. And in the same time, less cancers will be missed, there will be an enhanced diagnostic performance. And in a study assessing the impact of using the MRI morphology descriptors in characterizing 350 breast lesions, we found that malignant lesions significantly enhance higher than benign lesions. And this is an example how we can use this sign to differentiate between benign and malignant lesions. In this case, she came with bilateral mass lesions. One was rounded and one was oblong, but they were more or less circumscribed. We performed the contrast mammogram. The lesion on the left, on the right, it showed heterogeneous contrast uptake. There was another lesion anterior to it, and there was intraductal extension reaching to the nipple, and this was actually a triple negative breast cancer. While the lesion on the left, it did not show any contrast uptake, and it was simply a fibroadenoma. This is another 40-year-old female. She had a nodular breast texture, and this was how her mammogram appeared. She had bilateral multiple masses. When we performed contrast mammography, all the lesions on the right side did not show any contrast uptake, and they were followed up, and they were simply fibroadenomas, while all the lesions on the left side showed contrast uptake, and this was a multicentric invasive duct carcinoma. The absence of enhancement of a palpable or mammography identified breast lesion would highly suggest its benign nature, as according to studies, lack of enhancement has a high negative predictive value for malignancy. On the other hand, we have a few occasions when a malignant lesion is present in the breast, yet it exhibits no contrast uptake. This usually includes low-grade DCIS cancers and some lobular cancers, and sometimes it's not because of the carcinoma, but we have an exaggerated marked background parenchymal enhancement, which might mask subtle enhancement within the breast. And sometimes it's because of an improper technique that we do an improper imaging timing. These are two of very few cases that I have with high-grade malignant tumors that they showed no contrast uptake. The first was an invasive duct carcinoma, HER2 over-enriched, and the second case was a mucinous invasive duct carcinoma with mucinous differentiation. I don't find an explanation to this, but when we performed an MRI to these two cases, these lesions appeared very bright on the T2, which means that there was marked breaking down in the tumor tissue. Breast lesions on contrast mammography can be simply classified into non-enhancing and enhancing. We have under the non-enhancing lesions most of the benign lesions, but we also have a few malignant lesions. And under the enhancing lesions, we have most of the malignant lesions, but we have also a few benign lesions. And because of this overlap, we should refer to the BIRAD's lexicon of the mammography for the non-enhancing lesions and for the contrast mammography for the non-enhancing lesions. Before the contrast mammography lexicon, we used to follow the MRI morphology descriptors and we used to classify lesions seen on contrast mammography as enhancing mass, which is less than 5 millimeter, non-space occupying, enhancing focus, enhancing mass, which is 3-dimensional, and enhancing non-mass, which is an area non-space occupying. In the new lexicon, they decided to cancel the enhancing focus. They said that we do not see enhancing foci on contrast mammography, and they replaced this by an enhancing asymmetry, which to my opinion is not very logical, because if I come to characterize this lesion, I will describe it again. It's an enhancing asymmetry, and when I want to describe it, I will say it's a mass, the shape is so and so, and the margins and the internal enhancement pattern. So it's not very logical to cancel the enhancing foci. What would we do? Call these lesions, yes, this is the mass. The one here is a mass. We can describe it as a mass, but we cannot describe these tiny lesions as enhancing mass lesions because we cannot describe the margins, the shape, and the internal enhancement pattern of very tiny lesions. This is another case also with bilateral, multicentric, mixed invasive duct and invasive lobular carcinomas. Yes, these can be described as masses, but what about the enhancing foci? How can I call these masses? And I'm asked to describe each of them. For enhancing mass lesions, to characterize them, we should describe the shape, say whether it is rounded, oval, or irregular. We should describe the margin, whether it is circumscribed, irregular, or speculated, and we should describe the internal enhancement pattern, which is homogeneous, dark septations, heterogeneous, and rim enhancement. And going to the left side, we are mainly speaking of benign lesions, and going to the right side, we are speaking mainly of malignant lesions. And again, in the new lexicon, they decided that we do not see these dark septations on contrast mammography, although actually I have many cases, these are a few of them, in which the only sign which made us suspect that this is a fibroadenoma, it's not the intensity of enhancement, but the presence of these dark internal septations within the mass. For the enhancing non-mass lesions, to characterize them, we are asked to describe the distribution, which is either focal, linear, segmental, regional, multiple regions, or diffuse. And we are asked to describe the internal enhancement characteristics, whether homogeneous, heterogeneous, clumped, and clustered ring. And again, in the new lexicon, they decided that they would remove the clustered ring pattern. Although, again, I have some cases, but they are not here in this lecture. Together we're going to see how we can characterize lesions on contrast mammography. This is a 48-year-old female with a palpable left breast mass lesion. This lesion is enhancing. If I want to describe it, it is rounded in shape. It has speculated margins, and the internal enhancement pattern is heterogeneous. Then all signs pointing to malignancy. We can further confirm this with the ultrasound examination of the same patient, and this was her pathological axillary lymph nodes. It was an invasive duct carcinoma with level 1 amalgamated lymph nodes. Benign lesions also can enhance this. We have this case on the mammogram. We have this oval circumscribed mass lesion, and this is how it appeared on the contrast mammography. If we want to describe it, we will say it is oval in shape. It has circumscribed margins, and again, I see these dark internal septations, all features pointing to the diagnosis of fibroadenoma. This is another 45-year-old female with multiple left breast mass lesion. She had multiple lesions. This is her contrast mammogram. The first lesion here did not enhance, and this was actually a fibroadenoma. And the other lesion, it enhanced. If I want to describe it, I will say it's rounded, non-circumscribed with a homogeneous pattern of enhancement. There were additional features. There were pathological axillary lymph nodes, and there was internal microcalcifications, all features pointing to an invasive duct carcinoma. This is her ultrasound examination, pathological nodes. This is the mass, and this was the fibroadenoma. This was a female patient came presenting with bilateral palpable breast masses. The lesion on the right, it showed microcalcifications I will enlarge both of them. The lesion on the right showed microcalcification taking a segmental distribution, and the lesion on the left was circumscribed and it had fat content encapsulated. The microcalcifications are taking a segmental distribution, and the lesion on the left was rounded, encapsulated, circumscribed, fat containing. This was her contrast mammogram. The lesion on the right, it showed segmental heterogeneous numb mass enhancement, and the lesion on the left did not show any contrast uptake, and this was simply a hamartoma. If we diagnose breast cancer, we're also asked to stage this cancer or know how far has cancer spread. And to locally stage breast cancer, we should describe the size, the multiplicity, the lymph node status, and the presence of distant metastasis. And what we can only do on contrast mammography is assessing the size and the multiplicity of the lesion, but we cannot assess the lymph nodes or the distant metastasis. This was a 38-year-old female with a palpable right breast mass, and she had this lesion corresponding to the area of clinical concern, and it was said that she is a good candidate for conservative surgery. When we performed the contrast mammography, there was extensive infiltration of the right breast, and the management here changed from conservative surgery to mastectomy. It was an invasive lobular carcinoma. This is another 80-year-old female with a palpable left breast mass lesion. She had the lesion appeared irregular with the long spicule that was reaching down to the pectoral muscle. This is how it appeared on the ultrasound, and this is how it appeared on contrast mammography. We see that the spicule is enhancing down to the pectoral muscle. This is another case. She's a 47-year-old female with a palpable left breast mass lesion, and this area corresponded to the area of clinical concern. And again, it was thought that she's a candidate for conservative surgery. On performing contrast mammography, there were additional lesions not seen on the mammogram nor on the complementary ultrasound, and the management decision changed to an MRM. Now we'll move to the last step, and that is follow-up of patients. For example, we have this case. She's a post-operative. She did a post-operative case with marked parenchymal distortion in the right breast, but we can see operative scars which give us the same appearance on mammography. When we performed contrast mammography, we saw that there was enhancement all along the operative scar, and this alone indicated the presence of recurrence. This was another case that she had operative scarring also on the right side. We thought that there was recurrence. We performed a contrast mammogram, and we found that there was a contralateral incidentally discovered cancer. By the way, this is, I think, Dr. Maha Hlal's case. The operative scar on the right side, there was no enhancement, while there was an incidentally discovered breast cancer on the left side. Contrast mammography can also be used in the follow-up of patients receiving neoadjuvant chemotherapy. This is a 38-year-old female. She had a retroareolar mass lesion. It was enhancing, and they decided it was a triple-negative breast cancer, and she was a candidate for neoadjuvant chemotherapy. When she received the neoadjuvant chemotherapy and she came back with the mammography, on the mammogram we can never assess the residual lesion within the breast, but on the contrast mammography with a simple look, we identified that there is complete radiological response. And to end my lecture, the mission of all radiologists working in the field of breast imaging is not only to provide the best diagnostic options to our patients, but we should do so in a timely and convenient way. This gives us a great chance to make a marked difference in the lives of those who trust our knowledge and skills. Yet we have to admit that the challenge will always remain: how can we achieve this goal by using the right tools in the right time and place while maintaining balance with intricate economic constraints? And thank you.
Thank you, Professor Rasha Kamal, for the excellent and very informative presentation as usual. That makes the life of the neuroradiologist like myself to be easier in dealing with our patients. And now I have the pleasure to present my dear colleague, Dr. Iman Fakir, the assistant professor of the radiology Qasr Al Aini Hospital and the assistant manager of the breast imaging unit in Bahia Hospital. The Dr. Iman will present us a presentation titled as a contrast guided biopsy. Please, Dr. Iman.